Hello, welcome and good evening, guys. If I am audible and visible, if the AV quality is clear, just give me a quick nod. Is the AV quality clear? Am I audible? Am I visible? Is everything okay at the AV end? If yes, so then we are good to go for today's session. A quick nod and is AV good, guys? Are you able to see me and hear me? All right. Yes, 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 yes. All right, all right. So here we are for another session in anesthesia, and today we are going to be discussing a lot of clinical case-based scenario, right? Hi Rishi, hi Gulfaraz, hi Kishore, Arunesh, Mohammed Danish, Ayman. Ayman, what does Ayman mean? Pushpinder, right? So, all right, all right. So, a lot of you have joined in already. All right, so I am your host, your mentor, your educator, your friend for the subject of anesthesia on this wonderful, wonderful platform of Unacademy. Welcome, guys, for another session on anesthesia. And today we are going to be discussing a lot of clinical case based scenarios in anesthesia. All right, so before we start, a quick recap of what's going on our platform for the FMG students who all are planning to like go ahead with the FMG pack. FMG mastery has been started, and the 6 months offer price is only 15,300, right? And for those who are planning for NExT, that is 9 months pack, 17,000 is the price for that. And yes, it will be a combo of both the things, right? Your live as well as your recorded sessions, live plus recorded, that is NEET PG Vitals, which we have come up with, right? Okay. And for your final booster batch, which is there for the upcoming exam, and you can see that from February 22 to 28 there is this 20% off which is going on, so you can avail that as well, right? And for FMG June batch, from February 10 we have started with a course that is FMG mastery. The duration is 5 months. You can avail that as well for 20% off, which was going on. And yes, this is the code that you can use, that is Dr. Hitesh, for all your plans. All right, so I believe a lot of you have already joined. Everybody is good to go. Just give me a quick nod in the chat comment section so that we are good for our first question of the day, and it is here on your screen. Hi Harsint Mantri, how are you doing? So in CO2 absorbent canister, the greatest amount of carbon monoxide is produced by which of the following volatile agents, right? Halothane, isoflurane, sevoflurane or desflurane, right? In your CO2 absorbent canister, right? So this is carbon monoxide which is being produced by which of the following volatile anesthetic gases? Carbon monoxide is what? It is your greenhouse gas. Greenhouse gas, right? What do you mean by greenhouse gas? The gas which causes depletion of ozone layer. The gas which causes depletion of your ozone layer. Depletion of ozone layer, right? So that is known as your greenhouse gas. So which of the following causes maximum amount of carbon monoxide production? Difficult, eh? Yes. Is it difficult? Arunesh says it is D. Obito says it is D. Yes, let me know in the comment section, other people, which of the following volatile anesthetic agents causes depletion of the CO2 absorbent canister, right? Hi Shreya, are you still facing any technical difficulties at your end? Because right now I believe we are very good to go and the streaming is going on well. All right. So which of the following causes maximum production of carbon monoxide, guys? Is it halothane, isoflurane, sevoflurane, or desflurane? The correct answer here is desflurane, right? Desflurane, when it reacts with your CO2 absorbent or CO2 absorber, what happens? It leads to production of carbon monoxide, and carbon monoxide is nothing but it is a greenhouse gas, which is the result of your CO2 absorbent canister and reaction with your desflurane, right? So this is the reason why you will see we use desflurane less and less as much as possible. Why is that so, guys? Why is that so? Because we are environment friendly people, so anything which causes, though it is very minimal, but still it is there. So therefore we will what we will do, we will try and use desflurane as low as possible, as minimum as possible. All right, next question on your screen. A 44-year-old man with alcoholic liver failure requires general anesthesia for laparotomy, right? The surgery is laparotomy that is going on, and the patient is a alcoholic liver failure patient, right? The anesthetic agent of choice in such patient is halothane, isoflurane, sevoflurane, or desflurane. Again, the options are same: HISD, that is halothane, isoflurane, sevoflurane, desflurane. Write down in the comment section your correct answer. There are 2-3 important points here. One is the patient is of alcoholic liver failure, right? Which of the following is the anesthetic agent of choice? C, A, C, A, these are the options that are coming, right? So if I tweak the question a bit, guys, if I just tweak the question a bit, instead of anesthetic agent of choice, if I write here the anesthetic agent which should be avoided or contraindicated is, right, then what would be your answer? The anesthetic agent which should be avoided in such case, then what should be your answer? Yes, very good, Arunesh. Yes, Monica. Wonderful, Ayman, Kishan. Yes. So Obito, Arunesh, Harshit, Pushpinder. See, now you know that the agent to be avoided here is halothane. Why? Because halothane will cause H for halothane, H for heart, H for hepatitis. Right? Halothane will cause halothane hepatitis. So the agent to be avoided here is halothane, that we all know for sure, right? So which of the following is the agent of choice? For sure it's not going to be halothane. Right? Is it clear? So halothane is ruled out here. Right? So what are we left with? We are left with isoflurane, sevoflurane, desflurane. Desflurane, we have just seen that it is a greenhouse gas, so we will try and avoid it as many places as much as possible. Right? We will try and avoid it in as many places as possible. Right? So what we are left with? We are left with isoflurane and desflurane, right? Of the two, that is isoflurane and desflurane, which of the following has got minimum effect on hepatic blood flow? Which of the following has got minimum effect on hepatic blood flow? That is isoflurane, right? Hepatic blood flow. Hepatic blood flow. The minimum effect on hepatic blood flow is via this agent, that is isoflurane, right? Therefore we say, in other words, what we mentioned, the hepatic blood flow is preserved or best maintained by the isoflurane. Therefore in all your liver surgeries, in all your liver transplant patients, we prefer isoflurane. Isoflurane is the first drug of choice. Second drug of choice is sevoflurane. Clear? So correct answer here is isoflurane. Everybody understood this question? Nobody had mentioned about option B here. Here the correct answer, anesthetic agent of choice is isoflurane. Anesthetic agent to be avoided is halothane. Now you understand the difference between the two? Yes guys, everybody, now you understand the difference between the two. Such are the clinical questions that you have to understand. You have to give a minute more just to understand what they are trying to ask and then answer, right? Just this one word made a difference: choice and contraindication. Alright, moving on to the next question. Again, a 68-year-old patient is undergoing laparotomy for intestinal obstruction, right? The obstruction is found to be an ileal carcinoid tumor. The patient is a known case of asthma. Now here the drug of choice is, right? Again they are asking the drug of choice. Patient is a known case of asthma, right? So the drug of choice in this patient, again options are halothane, isoflurane, sevoflurane and desflurane. What would your answer be? Pushpinder says it's C, Harshit says it's C, Monica says it's C, right? So most of you are pointing towards sevoflurane, isn't it? Rest of the people, see, try and answer as many questions as possible here, because this is the place where you will answer, and if it's wrong, it's fine, right? At least you will know the reason why it's wrong, so it will be there in your mind, ingrained for your exams, final exams. Halothane is a vasodilator, but here vasodilator and asthma, is it interrelated? Yes. Come on, let us have a look at this once. Halothane, isoflurane, sevoflurane and desflurane, right? What happens to the bronchus? What happens to the bronchus when we are using all these inhalational anesthetic agent, right? First of all, see, there are two separate terms that you need to understand. One is your induction inhalational anesthetics during induction, and the second one is during your maintenance. Right? Maintenance. Induction means what, guys? Induction means what? When you are actually inducing, that is from your conscious state, you are making the patient to the unconscious state, right? That is meant by induction. So can we use inhalational anesthetic during induction? Right? Yes, we can. Can we use inhalational anesthetic during maintenance of anesthesia? Yes, we can. Right? So you will see that inhalational anesthetic is being used for induction as well as for maintenance of anesthesia, same as your IV agent, right? IV anesthetic agent. That can be used for your induction as well as for your maintenance of anesthesia, right? So when we are using inhalational anesthetic agent for maintenance, I am talking, right? For maintenance. When we are using inhalational anesthetic agent for maintenance, that time you will see that bronchodilator is the action of all inhalational anesthetic agent, right? I'll write here, all inhalational anesthetic agent cause bronchodilator. Right? All inhalational anesthetic agents are bronchodilators, right? When we are using them for maintenance, right? Maintenance. All right. Of those, the most potent bronchodilator is halothane. Most potent bronchodilator is halothane. Clear so far? Right? Now let us come to induction. That means when we are making the patient from conscious state to unconscious state, right? When we are making the patient from your conscious state to the unconscious state, when we are using it for induction, right? That time you will see that halothane and sevoflurane both are sweet smelling, right? So that is the time they will be used for induction, whereas isoflurane and desflurane both are irritant or they have got pungent odor, right? Suppose you are breathing somewhere, right, and you have a very good fragrance from around, right? What do you do when you have a very beautiful fragrance around? You take a deep breath, right? You try and take as deep breath as possible. But suppose you are there in an area and there is a very horrible pungent irritant odor, what will you do? You will just close your mouth and nose and you will try and take as less breath as possible during that area, right? So same way with isoflurane and desflurane, since they are irritant and pungent, the patient, since the patient is awake, will not try and take that deep breaths. Whereas with halothane and sevoflurane, since they are sweet smell, the patient will try and take that deep breaths and will be induced faster, right? So because of this irritant action, they are causing spasm. It can be bronchospasm, it can be laryngospasm, anything, right? Since the patient is conscious. So therefore, during induction, we say we can use halothane and sevoflurane. Of both, sevoflurane is more preferred, right? But here, what is the question? The patient is a known case of asthma and the drug of choice. Have they asked about induction here? No, they've just asked the drug of choice. So if you see quantitatively, all the drugs are bronchodilators, right? All the drugs are bronchodilators, right? But which of the following is most potent bronchodilator? It is your halothane. Halothane is the most potent bronchodilator. Clear, guys? Samjha? Did you understand this question? SIBO is sweet, yes, Obito. Therefore, it is used in pediatric patient, yes. Not just pediatric, in any patient, we will prefer sevoflurane induction, right? We will prefer sevoflurane induction. Sevoflurane is the drug of choice for induction, right? Sevoflurane is the drug of choice for induction of anesthesia. All right, clear? So everybody understood this question. See, clinical case-based scenario, sometimes we feel that it was so easy and I marked it correct. But when the examiner is trying to ask you, what the examiner is trying to tell you is something different, right? So fastest induction and recovery, right? This is related to your blood gas partition coefficient. Blood gas partition coefficient. Theoretically speaking, desflurane, it has got the fastest induction and fastest recovery. Fastest induction and fastest recovery. Theoretically speaking, desflurane is the fastest induction and fastest recovery agent, right? But do we use it for induction purposes? No, right? We cannot. Why? Because it is an irritant and pungent smelling volatile anesthetic agent which will lead to your spasm, right? It will lead to spasm, right? Clear, Megavi? Yes, it is an irritant, pungent odor. During GA, next question. During GA, that is general anesthesia, the purpose of giving glycopyrrolate is it muscle relaxation, analgesia, decreased secretion, or amnesia? Right? During GA, the purpose of using or giving muscle relaxant is, glycopyrrolate is, right? What is the purpose of giving glycopyrrolate? What is glycopyrrolate? It is an anticholinergic agent, right? And why do we use it? Yes, everybody of you have given correct answer. It is C, that is, it causes less secretions, decrease the secretions. Everybody of you have given correct answer. No need to discuss this in detail. It is an anticholinergic, glycopyrrolate, and second drug that we use is atropine. Second drug that we use is atropine, right? Clear? Moving on to the next question. Thiopentone is contraindicated in all of the following except, right? Look at this word. This is a girlfriend googly question again, right? Thiopentone is contraindicated in all of the following except. Yes, porphyria, status asthmaticus, pericardial tamponade, or penetrating eye injury. Yes, Monica, Shamir, Priya, all of you are correct. Yes, Biplab, very good. Rest of the people try and answer. Exception has been asked, right? So where will we avoid using thiopentone? Where will we avoid using thiopentone? Yes, does thiopentone causes precipitation of porphyria? Yes, it precipitates porphyria. Thiopentone precipitates porphyria. So can it be used in porphyria? No. Thiopentone is a bronchodilator or bronchoconstrictor. Thiopentone causes bronchoconstriction. Thiopentone causes bronchoconstriction. So again, It cannot be used in status asthmaticus. Pericardial tamponade, right? What is the effect on heart rate? What is the effect on blood pressure of thiopentone? Thiopentone causes fall in blood pressure, right? So in pericardial tamponade, can we use thiopentone? No, we cannot, right? So thiopentone cannot be used in pericardial tamponade. Again, gone. So what we are left with? Penetrating eye injury, right? We are left with penetrating eye injury. Is it clear, guys? Is the question clear? Hypertension and tachycardia, exactly correct, Sapna. It causes hypotension, because of which there is compensatory increase in heart rate. There is compensatory tachycardia, right? Exactly correct. Next question on your screen. 46-year-old female who was a case of multinodular goiter, right? She is posted for total thyroidectomy under general anesthesia. The intravenous anesthetic agent which do not have post-operative nausea, vomiting effects, which can be used in this patient. Right? Options are thiopentone, propofol, etoposide, or all of the above. Etoposide, thiopentone, propofol, all of the above. Somebody is selling C. Monica Priya says it's C, that is etoposide. Ayman, Sapna, Shamir says option B, that is propofol. Meghavi says C, again etoposide. Biplab, Vamshi, Oikawa. Kishore Kumar says B. So we are confused between option B and option C, right? So let us conclude that option B and option C are the most confusing options here, right? Yes. So the basic thing that we have to mark it out here is which do not have post-operative nausea and vomiting. If you want to summarize this in one word, that means it is what? Which of the following is antiemetic? Yes, we all have studied, we all have read about this property, right? We all have read about this property. Which of the following drug has got antiemetic action? Now, if you want, you can give the answer, right? Now, is it clear? We all have studied propofol, and there the options are, it is got the antiemetic property, right? Propofol has got antiemetic property, right? So the correct answer here is propofol. Was it easy? Yes, it was. But what happened in this disguise of this clinical case-based scenario? This became very difficult, right? Which intravenous anesthetic agent do not cause post-operative nausea and vomiting effects? That is, which of the following is antiemetic? It is propofol, right? In fact, etoposide is got emesis action, right? It has got that hiccups, myoclonus, right, and emesis, right? Any drug that will cause post-operative nausea and vomiting like thiopentone, etoposide should not be used, right? So therefore we prefer propofol over above drugs. All right. Next female who is a case of pleomorphic adenoma, right? Again, she is posted for parodontectomy under general anesthesia. Now, during induction, the patient was given vecuronium instead of fentanyl. The patient was intubated. This patient would have what? Amnesia, analgesia, muscle relaxation, or narcosis. What will this patient have? This patient would have amnesia, analgesia, muscle relaxation, or narcosis. What it is asking, the patient is given injection vecuronium instead of injection fentanyl, right? Exactly correct. So what is vecuronium? Vecuronium is nothing but it is a non-depolarizing muscle relaxant, right? So what will the patient have? Patient will have a muscle relaxation action instead of analgesic action, right? It is a clear-cut, easy question in which you are being asked the action of vecuronium, right? If you know the classification, you will automatically get to know that yes, it is a muscle relaxant. All right. Shall we take a couple of more questions? Yes. Shall we take a couple of more questions, guys? Let me know in the comment section. Which option are you talking about, Meghavi? Ketamine is the answer for other option. Which question are you talking about here? Alright, so next question. In patients administered with Propofol, which property of the drug allows for rapid recovery? Yes, in patients administered with Propofol, which property of the drug allows for rapid recovery? Elimination, absorption, metabolism, or redistribution? Yes, in patients who are administered with Propofol, which property of the drug allows for rapid recovery, right? So if you take Thiopentone, if you take Propofol, if you take Etomidate, or if you take ketamine, you will see that in general the patient usually awakens within 5 to 20 minutes at max, right? 5 to 15 is the ideal time, but the metabolism or elimination takes a far longer duration of time than this, right? Why is that so? Yes, is it because of metabolism or redistribution? Let us come back to our chart here. Yes, there is a phenomenon known as redistribution that you should understand, right? Whenever we give the drug, right, whenever we give any drug, where is the first concentration buildup of any drug? The first concentration buildup of any drug is in the vessel rich compartment, vessel rich organs. Which are vessel rich organs? Brain, right? Your liver, your kidneys, RS, or kidneys, liver, brain, lungs, these are your vessel rich organs, right? Second buildup is in the muscle rich compartment, in muscles, skeletal muscle, there will be the second buildup of your drug concentration. Lastly, it slowly and gradually builds up in your fats or fatty tissues, right? Fats or fatty tissues, right? So if you take it with regards to time, the buildup of the concentration of the drug, right? So if we give the drug at 0 time, right, and the buildup of the concentration is within 30 to 60 seconds, and it will last for around like 5 to 10 minutes, and slowly if you will see within 15 to 20 minutes the action or the drug is completely eliminated from the vessel rich organs, right? So where do this IV induction agents act? They act on the CNS, that is they act on the brain, right? So whenever there is this CNS concentration buildup, the patient goes into unconscious state, that is IV induction agents happens, and the patient becomes unconscious, and then slowly the patient recover within 5 to 15 minutes. That is because now the drug has been washed off from that CNS side. Yes, the drug has been washed off from that CNS side. Video is getting stuck, guys. That is what I am getting your reactions. Let me just now tell me, now is it any better? Yes, so it is because of this is known as your phenomenon of redistribution. This is known as your phenomenon of redistribution. Now is it better? All right. Right, so it is because of this redistribution, that the recovery is fast. Within 5 to 15 minutes the patient is awakened, right? It is because of this redistribution that the patient is awakened within 5 to 15 minutes. All right, it is not metabolism. If we are supposed to wait for metabolism at time, the drug takes 6 to 8 hours for the metabolism to happen and get eliminated from the body, right? So that is not the case. Clear? All right, shall we move on to the next question? Next question on your screen. Office colleague collapsed. Ambulances called for. ECG is taken. What will be the next line of management? We will check for pulse and breath. We will start with chest compression and defibrillation. We'll put the patient in lateral position and observe, or we'll do a cardio version in such patient, right? Not clear? Yes, are you able to see? Yes, is the AV clear now, guys? Or it is still lagging? Yes, most of you are giving correct answer. That is option B. That is chest compression and defibrillation. The ECG shows what? This ECG denotes what? This is the ECG of ventricular fibrillation, right? This is the ECG showing ventricular fibrillation, right? Audio is clear, video is lagging. No issues. We will just finish off with this, then we will take up. So here the ECG shows it is ventricular fibrillation, right? So whenever there is a ventricular fibrillation, is it a rhythm which shock can be given, or is it a rhythm which is non-shockable? Ventricular fibrillation is a rhythm which is shockable rhythm, right? So whenever you have a rhythm that is ventricular fibrillation and the patient has collapsed, right, and you are there in the ambulance as the first responder, what will happen? You will start with chest compression and you will try to defibrillate the patient, give shock as early as possible. As soon as possible, we will try and defibrillate the patient, right? So correct answer for this question is option B, that is chest compression and defibrillation. All right. Yes, it is a shockable rhythm. Exactly correct. So with this, guys, we come to the end of today's session. I hope this clinical case-based scenarios are there in your mind right now, right? Whenever you have a clinical question, remember to read the question twice, right? This will help you in solving and getting into the mind of examiner. Sometimes we try and slay as superficial as possible, but the examiner is trying to ask something else, right? So reading between the lines is most important, and correct comprehension of those words, of those meanings, of those lines is more important in clinical case-based scenarios. Alright guys, I hope you enjoyed today's session. That's all from my side today. So don't forget to subscribe for any of the batches that you are planning for Unacademy, right? Whether you are an FMGE or NExT aspirant. Remember, now we have come out with NEET PG Vitals, that is recorded plus live sessions will be available. Alright. So until we meet again, guys, this is your host, your mentor, your educator, your friend, Dr. Hitesh.